بسم الله الرحمن الرحيم. I would like to start this session, Sanofi Symposium. I'm very happy to be in this elegant meeting and thanks to Professor Dr. Magdi Abdelhamid for inviting us for this important conference. We have Dr. Khalid Leon, Basim Abdelhamid, Dr. Hussam Hassan, Dr. Samih Shaheen, Dr. Muhammad Gharib, Dr. and me, and Dr. Ahmed. And I think we need to start. As Dr. Muhammad Zahran with us?
Yes, Professor, I'm there.
Hello, everyone.
Okay, so our topic today is EC inhibitors, optimizing dose for maximum protection. Dr. Muhammad Zahran from Egypt.
To be here with you today. First of all, I would like to congratulate Professor Magdi Abdelhamid, the President of the Heart Failure Working Group, for the success of the conference. Congratulations, Professor Magdi, and all your colleagues in the Heart Failure Working Group also. Also extending this warm feelings to Dr. Khalid Chokri, the President of the Egyptian Society, and all his colleagues on the Egyptian Society board as well. So today we will be discussing an important topic.
Muhammad,
as we all know that ACE inhibitors
Muhammad, do you hear us?
Very well established and proven as morbidity and mortality game changers in heart failure. And as we all know that clinical trials year after year, more than 20 years ago, have proven to us that ramipril by name is one of the strongest medications in the field of heart failure. And there remains the issue, which is actually sometimes a puzzle. How can we optimize the maximum protection for our patients? And how can we reach the maximum dose? And is it important to reach the maximum dose or not? So we will go smoothly through this lecture. We'll be discussing first an introduction to the guidelines recommendation for heart failure management. What are the optimum doses for heart failure management? And do we have a comparison or an evidence that showed us that using the small doses does not offer us the same benefit as using the bigger doses? And how can we up-titrate from the smaller doses to the bigger doses? So as you see here, this is the famous slide from the 2016 European Society of Cardiology Guidelines for Heart Failure. If you have a patient with symptomatic HFrEF, you start by ACE and beta blockers, of course, class 1. And as you see, you need to up-titrate to the maximum dose, tolerated dose. If the patient is still symptomatic with a lower than 35% ejection fraction, you add the mineralocorticoid receptor antagonist, and you up-titrate also to the maximum tolerated dose. If he's still symptomatic, you will search for replacement to an ARNI or adding a CRT if he had a white complex, or reducing furthermore the heart rate. Combining all of the above, he still has symptoms, consider digoxin, hydralazine, isosorbide dinitrate as vasodilators, LVAD, heart transplantation, of course diuretics, symptomatic to resolve the congestion, and of course ICD implantation for VTAC or VF history. And this is, as they quote from the full text, that the ACE inhibitor should be up-titrated to the maximum tolerated dose to achieve the adequate inhibition of the RAS system. And sadly saying that there is evidence in clinical practice that the majority of the patients are receiving suboptimal doses of ACE. Of course, as you know, that's a class 1 class of recommendation that ACE inhibitors with symptomatic or asymptomatic LV systolic dysfunction and a history of MI to prevent or delay onset of heart failure and prolonged life. Also even without a history of MI, to prevent or delay the onset of heart failure. And even in patients with stable coronary artery disease who do not have an LV dysfunction, to prevent or delay the onset of heart failure. And in 2016, a recommendation for ARNI was if the ACE cannot be tolerated or as a replacement to ACE, or if the ACE failed, now you can start by the ARNI in 2020. So the American College of Cardiology guidelines, did they say something different? Actually, no. It's a class of recommendation 1 also, that ACE, ARBs, and ARNI, the clinical strategy of inhibition of the RAS systems with ACE or ARBs or ARNI in conjunction with evidence-based beta blockers and mineralocorticoid receptor antagonists is recommended for patients with chronic HFrEF to reduce morbidity and mortality. So ACE inhibitors should be started at low doses, up titrated to the maximum tolerated dose to reduce the risk of cardiovascular events, as we see. Why is this? Because the inhibition of the RAS system prevents the deleterious effect of the RAS system on the LV remodeling. And this is why the European Society of Cardiology dictated us to start the ACE inhibitors as soon as the heart failure is diagnosed, so you can start reverting this process. But as I said previously, and sadly, that despite you have clear guidelines recommendations, most of the patients do not get the full guideline recommended dose. What is the guideline recommended doses? This is an important question. As you see from the European Society of Cardiology, focusing on the ramipril here, number 4, you start by 2.5 and you reach a target dose of 10. Maybe the American have a different opinion? No. You start by 1.25 or 2.5 and you reach a target of 10. Maybe the British have a different opinion? No. They have the same opinion. You start by 1.5, 2.5 and you reach 5 milligrams twice or 10 milligrams once. I mean, in the 24 hours you need to achieve a 10 milligram. So the Europeans, the Americans, the British, they targeted a maximum dose of 5 milligrams ramipril twice or 10 milligrams once. Why? Why do we need to reach this dose? If we give a smaller dose, shall we get the same benefit? Let's see. 2017 European Heart Journal published this nice prospective European study about the determinants and the clinical outcomes of up titration of ACE and beta blockers in patients with heart failure. What did they say? Let's classify the patients to those who do not take the medication, who take less than half the medication, half the dose, who take between half the dose but not yet the full dose, and those who are achieving the full dose. Of course, if you're not taking the medication, the mortality rate is nearly 30%, and the mortality and or heart failure hospitalization is 50%. So the numbers are 30 and 50. If you achieve the full dose, the numbers are 15 and 30. So you get a 50% relative risk reduction. The 29 becomes 15, and the 50 becomes 29. This is a big relative risk reduction. If you're taking half the dose, the 29% is 25%, and the 50% is 39%. So actually, if you're taking less than half the dose, it's closer to taking nothing rather than closer to taking the full dose. And you still take one tablet. So why? This is the curves, of course, and also the same curves apply to the beta blockers, by the way. So the patients with HFrEF who were treated with less than 50% of the recommended dose of ACE and ARBs seem to have a greater risk of death and or heart failure hospitalization compared with patients reaching the full dose. Of course. Is there any other data supporting us? Let's see a meta-analysis. Meta-analysis for 6 studies involving nearly 5,000 patients in the low dose and more than 4,000 patients in the high dose. What's the objective? The objective is to investigate the effect of ACE ARBs on outcomes and drug discontinuation, especially with the higher doses in patients with HFrEF. What did they conclude? They concluded that in the patients with HFrEF, compared with the lower doses, the higher doses of ACE and ARBs significantly, though modestly, improved the composite endpoint of all-cause mortality and heart failure hospitalization without significantly increasing the chances of discontinuation. So, the patients can take the medication and up-titrate it to the maximum dose, and they will not discontinue the medication. So regarding Ramipril, what were the doses used in the clinical trials? HOPE, Heart Outcome Prevention Evaluation Study, New England Journal of Medicine, year of 2000. Nearly 9,500 patients, follow-up median of 5 years. Components of primary outcome, 3-point MACE, secondary outcome, revascularization, heart failure, unstable angina, diabetes complications. At randomization, the patients were assigned to receive Ramipril, of course, or placebo, at a dose of 2.5 milligram as a starting dose for 1 week, then 5 milligrams for 3 weeks until you reach the 10 milligrams dose for 4 to 6 years of follow-up. Wow. A relative risk reduction of 22% for the 3-point MACE, cardiovascular death, stroke, and MI. Cardiovascular death, stroke, and MI were reduced by 22% in the full dose of Ramipril compared to placebo. 23% reduction in the development of heart failure. Was Ramipril generally tolerated, or there were great incidence of side effects? As you can see here, cough occurred in 7.3% of the Ramipril group, leading to discontinuation. 2% of the placebo also got cough, by the way. Hypotension and dizziness, 1.9% of Ramipril, leading to discontinuation, which was also 1.5% in placebo, by the way. Do you see those as significant discontinuation reasons? Let's see. The IR study, acute infarction Ramipril efficacy study, 1993 in the Lancet. 2,000 patients were included. Acute MI survivors, early onset of heart failure, and they studied the primary endpoint mortality, the secondary endpoint progression of heart failure, occurrence of non-fatal infarction or stroke between the two groups. Ramipril 2.5 was the starting dose, up titrated to 5 twice, reaching a 10 or matching placebo, follow-up 15 months. This is the IR study. 77% of the patients were up titrated to the 10 milligrams dose without significant adverse events. As you can see there, 5/2 was achieved in 77%, 86% in the placebo, by the way. IR extended study. The extension study for the IR for the UK patients were 603 patients and extended the follow-up for 3 years after the end of IR to see if continuing on the full dose of 10 milligrams will achieve an additional survival benefit. And here you get this. The cumulative survival at 3 years and at 5 years was better with the Ramipril than placebo by 36%. So the Ramipril offered a survival benefit which was sustained for several years. And in the IRX, 79% of the patients were continuing on the 10 milligrams dose of the ramipril without significant side effects. So you have several tools in your hand. You have the 1.25, the 2.5, the 5, and the 10. Start low, up-titrate yourself slowly. You can achieve the 10 milligrams by up-titration every 2 weeks or even every 3 to 4 weeks. What are the main challenges for up-titration? Of course, lack of the health provider awareness. Let's get primary healthcare physician. He does not know the data that you are saying today. He can administer ramipril, he knows, but he administers the 2.5 milligrams and the patient continues on the 2.5 for the rest of his life. Unfortunately, this patient is deprived from the maximum benefit. Why? Because he does not have a clear titration plan tailored patient by patient. If I get the patient on day 1 with a blood pressure of 170 over 110, I can start by the high dose. If the patient blood pressure is 100 over 60, I will start by the small dose and I will up-titrate slowly. It is a tailored plan, patient-specific plan. And this will not be achieved unless I have a proper communication between, of course, the acute care, where they meet the patient for the first time, primary care, where they can meet the patient electively, and consultant care. Difficulty in managing adverse effects, like acute kidney injury, like rise of serum creatinine, like occurrence of symptomatic hypotension, and of course, repeatedly changing the regimen for the patient without telling him that this is for his own benefit. The patient may get actually clumsy and may stop his medication or withdraw his medication. But if you explain to the patient very nicely and very properly that this dose, maximizing this dose, will improve your chances of survival, will improve your morbidity and mortality situation and number, and you can show him some simplified charts to make it clearer to him, of course the patient will be very adherent to his medication because he will be seeking the benefit. What is the ideal up-titration measurement? As we said, the blood pressure and pulse should be reviewed, of course, prior to each dose adjustment. Start low, progressively increase. Intervals should vary from 1 to 4 weeks depending on the patient, on the medication. Actually, every 2 weeks they could be doubled. We need to up-titrate several drugs, by the way. We need to up-titrate the beta blockers and we need to up-titrate the ACE. So generally, only up-titrate once at a time if the patient is borderline hypotensive. If adverse effects arise, reassure your patients if they are transient, such as dizziness, and you can increase at a later stage. The patients elderly over 75 and with comorbidities are more likely to experience adverse effects. The diuretics also, do not push the diuretics and push the ACE and push the beta blockers. Of course your patient will be hypotensive. Be wise enough to manipulate the tools according to the vital data of your patient, and ensure also that the clinicians are involved with the patient exercise program for rehabilitation, should be aware of increasing the doses so the patient does not develop an injury during exercise. So as you see here, start only if the blood pressure is at least 100 systolic, potassium no higher than 5.5, creatinine than 250 micromoles per liter, and the GFR better than 50. Check your potassium and kidney function 1 week after the first dose. Provide a heart failure action plan. When up-titrating, double the dose at 2 weeks intervals, but not less than that. In case of hypotension, consider other blood pressure and lower medicine like as diuretics, or give your patient the dose before he sleeps so he doesn't have this hypotension during the day, during his walking hours. Of course, angioedema is an indication to stop the ACE, and if the potassium reaches 6, stop the ACE and seek a specialist advice. So we come to the summary and take-home messages. Despite the clear guidelines recommendations, sadly I would like to say that most of the patients with HFrEF do not get the guideline doses as targeted by the clinical trials. This is because of the lack of the health provider awareness, poor communication, and poor plan that is between the patient and the doctor and the doctors managing the patient. More than 75%, as we saw 77 and 79 in the IR extended, tolerated the targeted dose. So please, please, please be brave enough and wise enough to push your patients toward the maximum dose. And as ESC, AHA, and NICE guidelines, the dose can be usually doubled every 2 weeks.
Thank you, Muhammad, for this elegant presentation. I know that ACE inhibitors in the management of heart failure is now a cornerstone. So why do you think that why the patients are not receiving the maximum recommended dose according to the guidelines in the control of patients with HFrEF? Do you think this is because of the physician? They are afraid from the side effects, maybe from the hypotension that, you know that most of patients of heart failure with HFrEF, sometimes they have a borderline blood pressure. Do you think the adherence of this high dose, do you think the response may be due to the not following the guidelines? What do you think, Muhammad?
Yes, first of all, I would like to say hello to you because I missed you. I didn't meet you since a long time. So congratulations for the conference, and I would like to salute all the chairpersons with you. Actually, I think the issue is that the 4 available concentrations of the dose sometimes make the primary care physician a little bit clumsy to choose which dose for the patient. Sometimes some of the physicians believe that they have to start by the 1.25 dose. You don't need to start by the 1.25 dose. Sometimes if the blood pressure is 120/80, you can start by the 5 milligrams dose, and after 2 weeks you will achieve the 10 milligrams dose very easy. The problem is usually the physician starts by the 1.25 or the 2.5, and then the patient sometimes misses his follow-up for several months or maybe 1 year, and during which then the patient may stop the medicine at all or even continue on the 2.5 dose for a very long time. And he thinks that he is taking the ACE, and the primary care physician also, okay, my patient is an ACE, so he is on the medication. The problem is sometimes we see in ischemic heart failure patients, it goes like atorvastatin 10 milligrams, bisoprolol 2.5 milligrams, ramipril 1.25 milligrams, and nitrates 2.5 milligrams twice, and the patient said, I'm on optimal medical treatment. This is not optimal medical treatment. We need to emphasize, and this is our role as cardiologists, we need to emphasize that the optimal medical treatment to attain the full benefit that was obtained in a certain clinical trial regarding survival, regarding morbidity and mortality, should be following the same doses that were taken in those trials. In some selected patients, yes, you need to start by the very small dose if the patient is hypotensive from the start, but then this patient, you will tell him that he needs to visit you every 1 or 2 weeks because you will be pushing or up-titrating this medication, as we all do in our clinics. When we see the patient and diagnose him for the first time, we usually give him some more time than the following up patient, and we explain to him that this is not your final prescription. The prescription for heart failure is a staged prescription. We start by the initial one, and we explain to the patient that this prescription will be changed every several weeks. So the patient is already psychologically prepared that his prescription will be changed, and this has a survival benefit.
Yes, Muhammad, this is very important as you mentioned, and the most important thing that we always start with a small dose And sometimes you forget to increase the dose because you see the patient is okay. So I think this is very important. Don't be on a fixed small dose. You need to up titrate your dose, and I think unless it is tolerable, so you can increase your dose, because he will benefit definitely from a higher dose if you increase your dose for our heart failure patients. Thank you, Muhammad. I think Dr. Hussam, you need it? Okay. Dr. Ahmed? Any questions from the chairman or speakers? Okay. Thank you, Muhammad, for this very nice presentation, and I hope that we see you in contact again.
Hopefully soon physically, inshallah.
And thanks also for Sanofi for this great symposium. Thank you all.